In honour of Pulmonary Fibrosis Awareness Month, we're excited to bring you this important session on collaborating with your healthcare team for better PF care. We're fortunate to have an incredible lineup of speakers today, including both leading clinicians and a consumer who will share with us some valuable insights. Before we get started today, I will hand over to our speakers to introduce themselves so everyone joining can put a face to the name. So for our speakers, if you could please share a little bit more about yourselves to give the audience some context of your backgrounds, that would be fantastic. I'll hand over to you first, Megan, and we can follow the order on the slides after you.
Sure. Hi, everyone. My name is Megan Harrison. I am a respiratory physician currently working at Charles Gardner in Western Australia. I did my specialist training over in New South Wales, particularly at RPA, and then moved back to WA, my home state, about 3 years ago. My main interest is in interstitial lung disease, and particularly actually this topic about how multidisciplinary care can really enhance and improve patient care. I'm currently undertaking a PhD at the moment through the University of Sydney, where I'm looking at a treatable traits model of care, where we focus more about the patient rather than the disease process. And I'll talk a little bit more about that in my presentation. Thanks for having me.
Hi, everyone. Lovely to be here. My name's Kerry Hancock, and I'm a GP, and I am based in Adelaide. And at the moment, I'm also an honorary fellow in the Allergy and Lung Health Unit at University of Melbourne, and I chair the RACGP Respiratory Medicine Specific Interest Group. And for the Lung Foundation, I chair their Primary Care Clinical Council. So lovely to be here with you this afternoon.
Hi everybody, my name is Tara. I'm also based in WA, and I am the Respiratory Clinical Nurse Consultant, celebrating 35 years this year in cardiothoracic nursing, having worked in national and international locations. I currently work in a private practice attached to one of the private hospitals here in Perth. And I have a special interest in interstitial lung disease, and in fact established what we call nurse-led clinics in 2017, anchoring the long care, comprehensive care for patients and carers, and really importantly, providing nurse support for patients on antifibrotic therapy. I'm also a foundation member of the Australasian ILD Nurse Alliance Steering Committee.
Hi, everyone. Thank you for the invitation for being here. My name is Mariana. I am an early career researcher. I'm a physiotherapist by background. Mostly my research is being focused on pulmonary rehabilitation, oxygen therapy, and inspiratory muscle training with patients with chronic lung conditions, by specific interest now in ambulatory oxygen therapy and physical activity for people with pulmonary fibrosis. So happy to talk to you about that too. Thank you.
Laurie Hampton, age 83, a consumer, or maybe you should call me a patient, suffering with idiopathic pulmonary fibrosis, diagnosed in 2019, but had the cough for 3 years before that. So it goes back a little bit further. And I am a committee member for the Rare Lung Disease and a Peer Connect primary. Thank you.
Thank you so much, Laurie, and thank you to all our panelists. So I will start today's webinar with a presentation from Megan on multidisciplinary teams to help us demystify that process and understand its role in PF care. And then afterwards, we will have a pre-submitted question portion for our panel. And then end on the live Q&A session, as mentioned earlier. So feel free to submit any questions you have throughout Megan's presentation in our Q&A box that's located in the bottom of the screen. And we will get to those towards the end. So I'll stop sharing and hand over to you, Megan, to share your presentation.
Lovely. So yes, thanks again, everyone, for having me. I just thought I would give a discussion about MDT care in pulmonary fibrosis with a few aims. Try and introduce really what the MDT process is that we do kind of beyond the initial patient interaction, and try and give you a bit of an insight to what goes on really behind the scenes. Hopefully provide a bit of an insight into some of the reasoning behind our decisions, and also emphasize the fact that lots of people go into making each of these decisions and the importance of the MDT structure in pulmonary fibrosis. The way I'll do this brief talk is just talk about exactly what the diagnostic process is that should be done for each patient, how we actually run the ILD MDT meetings, and then kind of options regarding treatments and disease monitoring. So in regards to the diagnostic process, I'm sure many of whom are consumers, all remember the initial consultation, and this is typically undertaken by a respiratory physician. At the time, we undertake quite a detailed history, and we're looking specifically at a few things. The first is, which symptoms did you have and how much have they impacted your life? So we look at things like cough, breathlessness, weight loss and fatigue, and also try and kind of understand how much of an impact on the quality of life it's having. In this discussion, we'll often try and begin that delineating to try and figure out exactly what subtype of pulmonary fibrosis you have and whether we can actually understand what the underlying cause is. So we'll often ask questions about that would suggest that you have an underlying connective tissue disease. So things like, do you have dry hands, muscle weakness? Is it dry eyes, dry mouth and rash? We'll often ask detailed questions about what your jobs were in the past, just to try and understand exactly what your occupational risks were, and also environmental things like pets. Family history is also important in pulmonary fibrosis because it does often have genetic components. We try and understand that as well. In this time, we often will ask questions about your comorbidities just to get an understanding of general health, but also whether there are other pre-existing conditions which may be contributing to symptoms, but also may have an impact in terms of what therapeutic decisions we make or which treatments are offered. Sometimes we'll do symptom questionnaires. They're quite useful as a baseline and also help us further on as we understand the disease process. And we'll also undertake an examination where we look for markers of respiratory disease. So things like level of oxygen, the crackles, looking at your hands for clubbing, and then again, looking for underlying causes. So things like connective tissue diseases that help us figure out a bit more what type of interstitial fibrosis you have. Pretty much all patients will undergo these initial assessments, and often these will be done before that first clinic. So that's a CT scan of the chest where we can try and define a bit more the pattern of fibrosis, the breathing test or the lung function, where we can see whether there is restriction, so smaller lungs, or any limitation, the oxygen getting across, so diffusion. We also will often do a 6-minute walk test where we can see if your oxygen saturations actually decline, which suggests that it's harder for the oxygen to get across the lungs. We'll also do some blood tests looking at underlying causes and also your baseline liver, kidney and full blood count. And we usually do an echocardiogram, again, looking at the right side of the heart to see how much pressure it's been on during this fibrosis. In terms of the MDT discussion, this is the gold standard of pulmonary fibrosis diagnosis, and it's really the key recommendation in most international guidelines for pulmonary fibrosis diagnosis. Guidelines, so the American Thoracic Society and the European Respiratory Society recommend at a minimum you need to have a pulmonologist or a respiratory physician, such as myself. You need to have a radiologist and, if relevant, a pathologist as well. Other really key contributors that we really try and have at MDTs are the ILD specialist nurse, rheumatologists and or immunologists who are able to give a bit more insight in terms of connective tissue disease. The MDT discussion is often held in a room, either via Teams or actually in person, and it goes through a few stages. The first step is the clinical presentation, which is usually done by the respiratory physician that you've seen at that initial review. And the physician will present your case in terms of the symptoms that you've had, your comorbidities, lung function, and blood tests, and try and give the entire panel an understanding of what the disease process that you've been facing has been, and any suggestions of what an underlying cause could be. We then hand over to the radiologists who will go through the CT scans in quite a lot of detail, and they will look through any old CTs you've had to try and understand, again, what the temporal relationship's been. At this time, the radiologist will usually give what they think is the most likely pattern of fibrosis. Now, if you've had any pathology done, so that's usually either with a bronchoscopy where we push salt water in and suck it up, something called a bronchoalveolar lavage, or any lung biopsies, the tissue that was sent will be reviewed in this meeting by the pathologist as well. And again, they will give us a pattern of disease and try for us again to try and understand what subtype of interstitial lung disease you have. At the end of this, the entire panel will try and put all these 3 pieces of information together and make what we call a consensus diagnosis. Often about 15% of cases, we won't actually be able to define exactly what the underlying cause is, in which case those patients are called unclassifiable. At the time, we then discuss each patient specifically in relation to the priorities for them, their comorbidities and their pattern of disease, and come up with a list of recommendations. Now, you can see here, this is the output. This is from Charles Gardner. This is the MDT output that we use specifically, but many hospitals will use similar outputs. And this is also what we use on the Australian ILD registry. So you can see here, we say a consensus diagnosis. How confident are we in that diagnosis? And does this match connective tissue disease or progressive fibrosis? We then make recommendations in regards to each person's management, so whether we should observe, start specific treatments, undertake more specific tests, and then more detailed things, including things like lung transplant, genetic screening, or clinical trials. In terms of the treatment options, in terms of pharmacological options, antifibrotics are often the mainstay of our therapy in pulmonary fibrosis. And for us to be able to gain access to the PBS so that we can get government funding, the diagnosis needs to be made either through an MDT or in discussion with an MDT. And often we need pharmacology to help with side effect management. So particularly with antifibrotics, things like nausea or diarrhea. Other options that we might consider are things that will suppress the immune system. And those are typically used for lung fibrosis where there's a lot of inflammation. So things like connective tissue disease or hypersensitivity. And that's just a list of some of those immune suppressive medications. It's really important that we actually try and optimize other comorbidities. So things like reflux, postnasal drip, sleep apnea, because we know these each have impacts on pulmonary fibrosis. And then we'll often look into specific symptom-focused treatments, so things for cough, breathlessness. In regards to non-pharmacological therapies, I think I can say pulmonary rehabilitation is likely the most important and probably the most important intervention we have. We know that pulmonary rehabilitation has mortality benefit. And I think, from my experience, it really should be an automatic referral. So if it hasn't been discussed, I think it's really important. Some patients will need oxygen, and it's really dependent on what your oxygen is at rest, when you exercise, and often at night. And then again, we can use symptom targeted treatments. And this is often really where we utilize that multidisciplinary clinic. Physiotherapists, speech pathologists, and even dietitians are really helpful at this time, because often we know pulmonary fibrosis can really affect everyone in different ways, but also have significant impacts on things that affect your quality of life. Disease monitoring is, again, something that we need the whole MDT team to undertake. And I would say, often this is undertaken particularly by the ILD nurse, but ILD physicians, patient GPs, and also physiotherapists, again, particularly if someone's undergoing pulmonary rehab. In terms of disease progression, the things that we will look for are worsening symptoms, declining lung function, and more fibrosis on the CT. Symptom changes are often picked up not just at the regular 3 to 6 month ILD clinic, but often incidentally by the entire clinic. So often patients will present to their GP and say, look, I feel a bit more breathless. And I would hope that the GP and the ILD team have a good relationship in which that can be flagged early. Sometimes in pulmonary rehab, we know patients will go from walking 800 meters down to 4, and then that's often flagged again by the physiotherapist. And then if we see patients in their regular follow-up, we can notice that change, or sometimes patients will contact their ILD nurse and say, look, I think something's changing. We also monitor disease progression in patients who might be already on immune suppression. So things like connective tissue disease or hypersensitivity, where even though a lot of the disease is inflammatory, we make sure that we're monitoring for that scarring in case we might introduce another medication or the antifibrotic medications. We'll often look for disease complications, so high blood pressure in the right side of the heart, known as pulmonary hypertension. We make sure that the medications aren't having negative side effects and that patients are tolerating them well. And that's also often linked in with the ILD nurse. And then often as the disease changes, we think about things like palliative care or lung transplant referrals and more detailed things again, like if a clinical trial might be relevant. And also in terms of ongoing research about whether consumers might want to link in with a registry like the IPF registry or the ILD, Australian ILD registry. In terms of the future of the MDT clinic, I think this is kind of my area of interest and expertise, and I do think it's really expanding. My PhD, which is leading to a clinical trial here in WA, is looking at whether we can, instead of treating consumers or patients by their ILD subtype, have a look at each patient specifically and see what is important to them and what impacts them each. So we break this down into 4 domains. So etiology is, well, what are the things that are actually driving or causing the fibrosis? So things like, is it genetics? Are they being exposed to birds? Do they have an underlying connective tissue disease? We look at things that are affecting their pulmonary system. So do they have low oxygen? Is cough a significant impact? Do they have sleep apnea? Or are they at high risk of lung cancer? Then we look at things like extrapulmonary. So we know that pulmonary fibrosis can be linked with other comorbidities. So we make sure that we look and screen for those and treat them appropriately. And then behavioural things. So if someone's still smoking, can we help support them through that? Are they on a lot of medications, and can we rationalise those? The plan from us is that at Fiona Stanley Hospital, we're going to be running a trial where we actually do for each patient this kind of breakdown, and then we have an MDT where we say, well, these are all the traits that we've defined in each consumer, and then we target treatments based on those, with presence of a psychologist, a physiotherapist, a dietitian, and a speech pathologist, with the view that we might be able to improve patient outcomes. I think that's everything from me for now. So I'll hand over to the predefined questions. I'll just stop sharing.
Thank you so much, Megan. That was really insightful, and really sheds light on the behind the scenes as well of the MDT process. So thank you. So yeah, as Megan mentioned, we will now move on to the pre-submitted questions, and there will be opportunities for you to ask questions of Megan as well towards the end. So please submit any questions you have in the Q&A box, and we'll move on to our panelists. So the first pre-submitted question for today is for Kerry. So how do GPs contribute to ongoing care and monitoring disease progression while also maintaining clear communication with specialists? Hand over to you, Kerry.
Okay, thanks, Tara, and thank you, Megan, for a fantastic presentation. It was I really enjoyed it, and I'm sure many others did as well. Now, I'm a GP, so I get to answer this question about how GPs contribute. So I'm sure many of you, if not most of you, know how valuable the relationship is with your GP. Your GP knows you, your community, maybe your family, and even your extended family. While your lung specialist, such as Megan, will usually have led the diagnosis and implemented advanced treatment for you. And of course, he or she knows a lot about lungs, but your GP knows a lot about a lot of other things. So if you have other conditions such as maybe diabetes or hypertension, osteoporosis or arthritis, all very common comorbidities, then your GP is the right person to manage those, and if necessary to coordinate referrals to other specialists if need be. Your GP is the one who will be monitoring you for other conditions, and these might include conditions such as diabetes, elevated blood pressure, heart disease risk, osteoporosis, cognitive decline, and your psychological well-being. Your GP will be the one who is most up to date about vaccinations, what is needed, what is funded, what's not funded. And that has certainly been a changing and challenging landscape in the recent past and will continue to be so into the future. So many vaccines on offer these days. You should be able to access all the government-funded vaccines through your general practice and maybe some of the private ones as well, such as whooping cough and RSV. Your GP can facilitate access to community-based services such as physiotherapy and exercise programs and mental health services if needed. This would most likely be done via what we call care planning for a chronic disease. And your GP might also involve the practice nurse in this process and arrange for the care planning to be reviewed every 3 to 6 months or so. These care planning visits with your GP and or your practice nurse are rebated by Medicare, and many GPs do bulk bill those services, but not all GPs do though. Some of the allied health and the mental health services are also Medicare rebated. However, these days there is often an out-of-pocket gap payment required by these health professionals as well. However, your GP or practice nurse may know where the good but cheaper services are. Your GP can also quite easily arrange a referral to a specialist pharmacist for a home medicines review, where that pharmacist spends time with you reviewing and discussing all of your medicines in the comfort of your own home. A report will then be provided by that specialist pharmacist to your GP, who will then discuss it with you, usually at a formal consultation, or it might be over telehealth. And that's all paid by Medicare. This service is especially worthwhile if you're on multiple medicines or starting on new medicines or struggling with your current medicines. Your GP will work in collaboration with your lung specialist as to how to monitor your lung condition, as Megan said before, what tests are needed and the timing of those, and when specialist review is required again. As part of good clinical practice, GPs and lung specialists will formally write to each other about you. However, most lung specialists that work in this field of pulmonary fibrosis are very happy for GPs to contact them directly at any time if they have any concerns about their patient. Your GP will usually be your first port of call if your lung condition is flaring up, as Megan said before. They can make an assessment and discuss with your lung specialist what action to take. And certainly your GP knows how to get past those people at the hospital switchboard or the specialist reception staff. They're very good at doing that. I truly hope that you have a compassionate and patient-centred GP who is there to provide support to you and the special people in your life, to provide information, to seek answers to your questions, to help you quit smoking if you're a smoker, to help you prepare advanced care directives if that's necessary, and everybody does need one of those, to be a facilitator and a conduit to good health care for you, and all in all, to keep you well. So thanks, Tara, and I'll hand over to the next question and answer.
Thanks so much, Kerry. That was a very comprehensive response and very helpful as well. Thank you. So we will now move on to the next question, which is for our ILD nurse. So what is the role of an ILD nurse within my care team, and what key questions should I be asking to make the most of their support? So over to you, Tara, for this one.
Thank you. Thanks. Hi, everybody. What is my role? Could I say that we do everything? But as ILD nurses, we play a pivotal role in your care team, which extends also to your family and also carers. We are there throughout all stages, anchoring patient care from the initial meeting and diagnostic stage guiding the patients throughout the chronic disease management phase and supporting the end stage phase. ILD nurses, we bring unique skills to the team, particularly in managing chronic diseases. We provide comprehensive education and advice on disease processes and management that also includes symptom management such as breathlessness, cough and fatigue, and offering the extra medication support. Our expertise in troubleshooting the side effects, especially associated with antifibrotic therapy, actually equips us to share tips and strategies that help our patients stay on therapy for extended periods. We also advise on oxygen therapy, lifestyle modifications, social psychos support is offered, and signposting to patient support organisations. So we really get to know you, and actually you get to really know us too. We also play, you may not be aware, a proactive behind the scenes role in coordinating your care with liaising with your multidisciplinary team members. So as Dr. Harrison's always mentioned before, we are often the first point of contact for medical and allied health teams. This is especially true for our regional and regionally remote patients here in WA, where our accessibility can make a significant difference in a patient's care. For an example, we may identify a patient who needs an urgent review from being contacted by the patient's GP, such as Dr. Hancock. From that, we can act swiftly by bringing this to the attention of the treating specialist, and then may assist in expediting an urgent review or even admission. For our remote medical teams, because Western Australia is such a large state, sometimes they will call me first if they need to contact the patient's treating physician urgently. I support 7 specialists here in our practice who also work at other tertiary hospitals, acknowledging Dr. Harrison is one of the doctors I also support. And if they have concerns about a patient, I'm contacted and alerted to that problem. In fact, I came to work this morning and there was an email from one of our specialists asking me, could I keep an eye on a patient's blood results? So in fact, one of our doctors here at our workplace, he refers to this ILD nurse support as having a secondary pair of eyes. So I could be so bold as to toss it out that the ILD nurse is the glue that holds your MDT team together, but we all have a primary focus on anchoring patient care. The second question that I've been tasked to answer is what are the questions that you should be asking the ILD nurse? On reflecting and preparing for today's talk, I think the first question you should ask, is there an ILD nurse within my MDT? I'm aware that not all ILD centres throughout Australia have an ILD nurse, and it's an issue that we're currently addressing as a professional nursing body. If you don't have an ILD nurse with your support team, I suggest the first question is you ask your specialist, why not? What is the best question? Any question is a good question. If you have any questions or concerns and don't know who to ask, I encourage you to start with your ILD nurse. We are often the main point of contact for patient questions and concerns, and typically have a little bit more time to spend with patients. We can, on most occasions, answer your question or find a solution in obtaining an answer to your question. You need to ask how you can contact the ILD nurse. For our patients that I look after and care for, they can contact me via phone, text, email, or come in and see me face to face. It's the best part of my nursing role, and also I love a chat. To give you some examples, some of the conversations I had last week, a patient contacted me after being listed for a lung transplant, and she wanted to share her concerns and feelings about this with me. Another patient contacted me just to let me know how they were going on antifibrotic therapy and to share with me if they were experiencing any side effects. And thirdly, a patient contacted me just to alert us that they have COVID last week, and they wanted to know what they should do. As ILD nurses, being part of your MDT, supporting you and your family, advocating, and sometimes being behind the scenes voice is a privilege. So thank you.
Thank you so much, Tara. That was very insightful and helpful to know as well. And yeah, to your point, I think it's important to know how to advocate for yourself. So thank you for the practical tips as well of what questions they should be asking and yeah, how to find an ILD nurse as well, which is very important. So we will keep moving. If there are any questions for any of the panelists, I encourage you to please submit them in the Q&A box in the screen, and we will get to those shortly. But we will move on to the next question for today, which is for our physio, Mariana. So Mariana, what are some of the most effective exercises or techniques I can use to improve my breathing and overall health? Over to you.
Thank you. Thank you so much for the question. This is a very important question, and it's a challenge to answer this question in 5 minutes, but I'll try my best. I could stay literally an hour talking about exercises and the best exercises for pulmonary fibrosis, but I think I'll start with the most effective exercise or technique is actually the one that you have a good adherence to it. So the one that you actually perform regularly. So the one that you introduce to your life and you actually can keep doing in a regular basis. I would say for someone that has not an exercise routine, a good way to start is with pulmonary rehab. So like Megan has stated with us, pulmonary rehab is safe. It's a safe treatment, is an effective treatment. It is on the guidelines for treatment of pulmonary fibrosis, and it's already proven with many evidence and articles in the literature that it improves not only exercise capacity and quality of life, but also breathing and breathlessness immediately after the intervention. For those who don't know what pulmonary rehab is, it's normally an 8-week exercise training. And when someone doing rehab, what do they do in those sessions of exercise? They normally would do aerobic training. So either they would go on a treadmill or on an exercise bike for a couple of minutes, so 20 minutes, 30 minutes. They will also do some resistance training. So they will do some weights, then you do weight machines. They will also have an education component with pulmonary rehab. So that's when you would talk with your physiotherapist about breathing techniques, and you talk about how to introduce exercise into your daily life and into your routine. And that's how you also build the confidence to keep exercising when you finish the program. So the program usually runs for 8 weeks, and it can be an outpatient sort of program. So you go to a pulmonary rehab center that could be in a hospital, in a community, but there are some centers in Australia as well introducing some home-based and tele-rehab that has been shown as well to have the same benefits in terms of improving quality of life, improving exercise capacity and breathlessness, even if you don't go to a specific center to do pulmonary rehab. So I think, number one, if you haven't done one before, if you haven't done any exercise and you're thinking about exercise, pulmonary rehab is a very good start. Talk to your specialist, your GP, so you can get a referral to a pulmonary rehab close to you, or talk to your specialist as well to how can you do it, maybe home-based or in tele-rehab if you don't actually have access or if you don't have how to come to the rehab center. If you have done pulmonary rehab, it's been a while, it's always worth doing it again. So I have a brilliant colleague of mine here in Monash University made a comment today to me that our lungs are pretty much like a car. So if you service your car last year, you might as well just service in 2 years after. So if you've done your rehab 2 years ago, it might be time to do your rehab again if you haven't created an exercise routine. So if you have done one lot of rehab before, but it's been a while, it's worth maybe thinking about it as well. And if you have done pulmonary rehab and it hasn't been a while, you can always go to the Lungs in Action, which is you go on the Lung Foundation Australia website, you try to find information about the Lungs in Action, which is a way for you to keep doing what you were doing in rehab. So keep exercising, but then you will find centers that will help you to maintain that exercise habit after that. So the Lung Foundation is the Lung Foundation Australia, and the Lungs in Action is actually a very good way for you to keep doing the exercise routine that you will learn in rehab. And in terms of the techniques and breathing techniques, in pulmonary rehab, you'll have a physiotherapist and you can talk to your physiotherapist about what are the breathing exercise that you can learn and you can introduce when you're doing exercise. So then once you finish rehab, you can keep doing those techniques when you practice your exercise by yourself. And I think that's it from me, but happy to answer any other questions as they come along.
Thank you, Mariana. That was brilliant. And yes, a very good point as well around lungs in action. So yes, you were right. The Lung Foundation website does have a directory where you can find both pulmonary rehab near you as well as lungs in action classes. But yeah, thank you. So I can see some questions are starting to trickle in. So please keep submitting them. We are on to our last pre-submitted question for today. So we will get to the live Q&A shortly. So last pre-submitted question is for Laurie. Second last, my bad. So this one's for Laurie. So what challenges have you faced in navigating the healthcare system? And what tips do you have for other consumers to advocate for themselves and build a strong support network? So I'll hand over to you, Laurie, for this one.
Thank you very much. My challenges have been mainly with the medical system, and those were at the very beginning when I developed the cough. With developing the cough, every time I went to my GP, he would just fob me off, take some cough mixture and carry on until in the second year, I had to go back to him again, and the cough hadn't deteriorated any at all. So then he decided to send me on a lung function test, which didn't show up very much. And then I went for a CT scan, but only on the front side of my chest. So after all this, the cough was still there and I wasn't getting any further advanced. I changed my GP. The GP that I had was not really looking after me very well. So I changed my GP in the same clinic, but the new GP I got had actually dealt with an IPF case while he was working down in Tasmania, and he had some insight into what the disease was like. So he then sent me back for further CT scans, and still no answer. And I was away on holiday and the cough developed again. And I went in to see if I could see somebody in the public hospital system. And all they did was take x-rays of my lungs and just came back and put me on some medication, which brought me out in a rash, and they had to change that. And when I got back, I went back to my GP, and he then sent me for a CT scan front and back. And that's when they discovered the scarring on the lungs. And from there, I was sent to Lyell McEwen Hospital to see a specialist out there. And this gentleman, all he was interested in doing was doing a biopsy. And I said, "Oh, is that where we start, is it?" And he said, "Oh, I think so." So I said, "Okay, we'll leave that one, and I'll see if I can find somebody else." So then I was going to go to a private pulmonologist, but my doctor sent me. I then got a referral again from my doctor to go out to Lyell McEwen, and they put me on to another physician who was very, very good. Michelle Wong was her name. She's the head of the pulmonary department at Lyell McEwen now, and she has really worked me over, and she immediately put me onto OFEV, on 150 milligrams, and that seemed to, the cough virtually went away. It has come back again, but I got her to drop the dosage from 150 to 100 milligrams because I was having a terrible amount of trouble with diarrhea and nausea. And on the 100 milligrams, I still get the diarrhea, but the nausea is only very occasional. And I'm learning to live with it. And I would say that the best thing I can say to anybody who has the disease is to do a lot of reading, which I did. I read everything that the Lung Foundation had on IPF. I went into the American system, and I'm now a PF warrior over there. And I've watched their Facebook page every day and catch up with everybody. And I get a lot of information out of my peer group called IPUF. And we, I would say, do as much reading as you possibly can. And I've found from being in Peer Connect that a lot of my peers that I talk to are still having a lot of trouble with specialists who say, oh, you know, you've got 3 to 5, make the best of it. And I think there needs to be a lot more education in our physicians and specialist network so that people are not put into that mental position that they think they're on a down and an out. So I just get up in the morning, and if I can, go out and smell the roses, because today is a new day, and make the best of every day you have and keep on smiling. Thank you very much.
Thank you, Laurie. That was beautiful. Thank you for sharing your lived experience with us. And some really, really valuable tips that there as well around how to really advocate to build a supportive healthcare team around you and not just accept, you know, what you might be given. You know, we do often say sometimes you might need to shop around for the doctor that's the right fit for you. So yeah, you're a beautiful example of that, and now feeling quite well supported. And peer support as well being a really powerful tool to provide that support as well. So I will share a bit around peer support towards the end and how you can connect with that. But yeah, thank you for sharing that with us, Laurie.
Thank you.
So we will move on now to the last question for the day before we go to the Q&A session. So this one is around what are some effective strategies or treatments available to help reduce cough? So I'll hand over to Megan first to share from a respiratory physician perspective, and then we'll follow with Mariana from a respiratory physio perspective as well.
Sounds good. Thanks, Tara. This question is hard, I think, because cough we know is very common in interstitial lung disease. I think there's reports that about 85% of patients with idiopathic pulmonary fibrosis have cough. And we don't exactly understand the mechanism. We know that there's some kind of receptor that gets stimulated in the chest, either through a mechanical stimulation or chemical. And we know that cough not only impacts quality of life, but does have negative outcomes. The way I approach cough in patients is first, and I think probably most important, is look for any co-contributing factors that might be driving the cough. While cough, obviously, we see a lot in pulmonary fibrosis, there's often other things that are contributing and that are much more easily managed. And so if we look for and target those, often we get quite good results. Important things that I will usually look for are things like reflux. So sometimes if you're getting some indigestion, it's quite subtle, we can try reflux treatment. We wouldn't blindly treat everyone for reflux because we know that that actually doesn't work. Things like sinus congestion and postnasal drip are important to treat. Often there's just vocal cord dysfunction where essentially your vocal cords can get overexcited and that can cause a cough. And also things like airways disease, so asthma and smoking as well. Once we've identified and managed any of those comorbidities, then other therapies, which I'm sure Mariana could probably talk more to, are really important. And some of those are actually things that are called cough suppressive therapies, where through the guidance, often of speech pathologists or experienced physiotherapists, we actually have specific techniques where through practice and almost training, we can actually try and suppress the cough. So things like cough suppressive swallow, controlled breathing, and relaxed breathing. Then we kind of have medical options, which are more challenging because the evidence base is pretty slim. And obviously with medications, they all can have side effects. It's often a weight off that's causing you a lot of distress, which we often see. Then some of these pharmacology therapies are actually an important option. So that's things like there's specific medications, so things like gabapentin. Sometimes we can use opioids in very specific situations. And then further down the line, there's some clinical trials in cough, and then also there's a small potential. I know some people are considering things like Botox. So we do have options. It's definitely a challenging area, and I really think it's an important area that we need to do more research in, really, because clearly it has a big impact. So maybe I hand over to Mariana.
Thank you, Megan. And yes, I would agree with that. The first thing is important to know what's causing the cough. If obviously we have a reason, then we could go more into medications and stuff. But if we actually don't have the reason, if it's not reflux or if we can't connect with anything, in terms of the physio perspective, what we could try to do is techniques or breathing techniques that could help either stopping the cough or like suppressing the cough. So techniques that your physio is going to teach you when the moment of the cough comes, how can you hold your breath and then control your breathing after that to try to suppress that cough. If it is a cough that has a production of mucus and it is a productive cough, there are techniques we can use as an airway clearance as well. So we use postural drainage, or we use positions and sit down positions and breathing exercise in different positions so we can move that mucus out and then expel that mucus to avoid future cough as well. If we know the triggers of the cough, obviously we'll try to educate the patient to try to avoid those triggers. And obviously, if it is something about learning how to breathe and talk, because if it's the talking is what's causing the trigger of the cough, then we will practice breathing exercise and talk, and then doing more pauses while talking, so then we don't go to a point where the talking is actually causing the cough. We obviously instruct on a lot of sips of water very frequent during the day, so we avoid the dryness of the throat as well that can trigger the cough as well if that's the case. So we'll have a range of techniques and things that we could try to see if we can improve the cough if we don't actually find a specific reason why medication can be used for that. And other things such as avoiding alcohol, caffeine, and if it's asthma that is causing it, we can always use inhalation. So there are a number of things we can try, and if we don't have a specific cause, we will try breathing exercise for that as well.
Thank you, Mariana, and thank you, Megan. And yes, again, very helpful strategies as well for our audience today to take away. So just in the interest of time, I will quickly move along to our Q&A session. So as mentioned, the questions should be of a general nature. We can't take any individual specific questions. Those should be consulted with your training doctor. But we did have a few questions. We'll try and get through as many as we can. So the first question we have is, what are the oxygen therapies available? Are there any benefits to hyperbaric chamber therapy? Would any of our panelists like to start for this one? It's open floor.
So I suppose in terms of oxygen therapy, the way that we tend to look at it, as I briefly mentioned before, is in 3 categories. So there's resting hypoxia, which means that your oxygen level is low just when you're sitting down. Exertional hypoxia, which I think Mariana probably speak the best to, which is when your oxygen level drops. And we usually say it drops less than 88% when you're walking. And then also the nocturnal hypoxia. So when you spend more than, we usually say about 10% of your time having a low oxygen when you sleep. In terms of the oxygen therapies we use, we know that if patients have a low level of oxygen, which we measure on an arterial gas, then we tend to give them oxygen. We don't actually have any specific or very big data from interstitial lung disease or pulmonary fibrosis. Most of our data is actually taken over from our COPD colleagues, where we showed back in kind of 1978 that if people have very low oxygen, by giving them oxygen, we improve the length of their life and the quality of their life. And so that's what we do. Exertional oxygen, I think is probably more of a challenge. I think that's what Marianne's study is really important in looking at. We want to try and understand whether having oxygen when you walk, so when your oxygen is low, and trying to improve that, does actually have a significant impact on the length, on your mortality or the length of your life. And then nocturnal oxygen, we tend to have a look at with a sleep study, because often you can get sleep apnea, and we can think about oxygen in that time. In terms of hyperbaric oxygen therapy, it's not something that we tend to use in pulmonary fibrosis. And I don't know, I haven't seen any evidence about that. I can't say, I don't know if anyone else on the panel has, but it's definitely not any of the kind of first few lines of therapy. So there's no trials underway with that either. So not from my experience, no.
Thank you, Megan. Any other comments from the panelists? I'm happy to keep going.
I would just add to what Megan said. Yes. So what we know so far is about exertional oxygen it's the results of the study. It's about to come. So we'll have luckily and very soon we will understand a bit more if oxygen on exertion, which what Megan said, that if your oxygen levels drop when you're actually doing an activity, when you're performing your exercise, the study's results are going to show if we provide you oxygen for you on those moments, if actually going to make you feel better, feel breathless, and actually perform better the activity. So this was a huge gap for us. We didn't know if oxygen would help people with exertional desaturation, with exertional low levels of oxygen. So I think it's a space to keep an eye for the next couple of months, because then it would highlight much more, as well as patients' experience. So everyone in that study used a portable oxygen concentrator, which for those who doesn't know, it's not a cylinder. So it's a machine who provides oxygen, and it's a portable machine. So we will have experience of patients that use that machine if they actually felt the difference when they were performing exercise. So the results are about to come, and I think it will highlight and it will give us much more insights on the role of oxygen for patients with pulmonary fibrosis.
Thank you, Mariana. So unfortunately, we have run out of time to continue with the Q&A session, but that's okay. I will run through where you can direct any further questions you have in a second. But just wanted to say a big thank you to our amazing panelists for giving us their time and sharing their insights and experiences with us today. It's really been a pleasure to have you with us. Personally, I've learned a lot from this session, and I assume that our audience probably would agree and has found this as inspiring and informative. So just as I mentioned, if you did have any more questions following today's webinar, please feel free to reach out to our Information and Support Centre. The free call number is on the screen, as well as the email. So either means to contact us, and if you have any specific questions, we can try our best to find the answers for you. You can also visit the Lung Foundation Australia website via the QR code on the screen that will link you directly to our pulmonary fibrosis resource hub that contains a wealth of information and knowledge and resources that's been developed by clinicians and consumers just like our panelists here today. So I'd encourage you to have a look at some of those resources on there if you haven't already. And just also wanted to touch on our peer support services that Laurie also mentioned. So we do have online support groups, some face-to-face support groups in certain areas, as well as our one-on-one telephone-based peer connect service. So these are all for anyone living with pulmonary fibrosis or interstitial lung disease. And again, you can ring our information and support centre to find out more about how to connect in with those groups. So thank you again to everyone for joining us. We hope you found this session valuable in learning about how to better partner with your PF healthcare team. And we hope you have a lovely rest of your afternoon and take care. Thank you, everyone.